Okay, so I'm going to do this talk in behalf of Dr. Biju, who could not be here. So I'm going to talk a little bit about viral infections post-transplant. The majority of the audience I know are transplant physicians, and I'm going to go through a few basics because I've also been told that there is quite a bit of students out there in the audience. So as most of you all know, a stem cell transplantation is a process by which conceptually, any genetic or acquired disorder in the hematopoietic stem cell can be corrected by transplanting from a potential donor. And usually this involves taking a patient through chemotherapy and radiotherapy, ablating the bone marrow, infusing cells from a donor who does not have that particular problem. And usually we do have a well patient. But during that entire process of chemotherapy and radiotherapy, there is a fair amount of ablation of the bone marrow. And these are the classical stages of reconstitution following an allogeneic transplant. You have the pre-transplant phase, you have an engraftment period, and what you're seeing over here is the neutrophil counts in the patient goes to a very low level, and it takes about 2 weeks to 3 weeks at times to return. Then there's the early post-engraftment, and usually when we talk about engraftment, we focus on platelets and neutrophils. There's an early post-engraftment and there's late post-engraftment. And what a lot of attention is not often given, especially from a student perspective, is that while we focus on the neutrophil engraftment, it's important to remember there's a whole set of innate and adaptive immune system that has to recover post-transplantation. So the NK cells recover fairly rapidly. In our own published data, by day 28, you get almost pre-transplant normal levels of NK cells. But the T cells and B cells can have prolonged low levels, and the inverted CD4 to CD8 ratio can persist for up to a year post-transplant. So based on these parameters, we know that different types of infections come out at different times. So during the early engraftment period, when there's mucosal damage and neutropenia down, you're often looking at bacterial infections, HSV, and in the post-engraftment period, where there is viral reconstitution yet to fully happen, a number of viral infections can come on. HSV infection persists. CMV infection usually comes on from the early post-engraftment period around day 28. Day 14 to day 28 onwards is when we start looking at an increase in CMV infections. So at Velo, we did our first transplant way back in 1986, then the first autolog was 1922, a haplo in 2003, first mud in 2008, and the haplo-identical PTCY from 2010. At present, we do about 250 to 300 transplants a year. And you can see in 2019 of 230, there are increasingly more and more complex transplants being done, including 96 haplo and 27 muds. And that's the split up of the type of transplants that we do. Third is hemoglobinopathies. Another third, aplastics, and most of the others are malignant disorders. So if you look at our data in the pre-haplo, pre-mud era up to 2001, and this is data that we published on 304 transplants, that was the breakup of viral, bacterial, and fungal infections. Surprisingly, tuberculosis is fairly low, and viral, mainly CMV, was seen in about 22% of patients in that series. Again, this is a series of patients where there was practically all matched sibling donor transplants. Viju has put this data together of a more recent cohort, and this period involves much more complicated transplants, mismatched transplants, unrelated donor transplants, haploidentical transplants, use of fludarabine, more use of anti-thymocyte globulins. Again, you can see over here that sibling donor transplants are about 1,660, haplos about 248, and muds about 236. Viral infections in this series, about 519 recipients, 35.4 patients had, 35.4% had viral infections, mainly CMV, BK, and respiratory viruses. As all of you all know, in CMV, there's a high seroprevalence in India with 95, 98% of the population being seropositive, in contrast to about 38 to 75% in the West. And the patient and the donor serological status remains the most important cause of CMV viremia in a Western population. And this is fairly old data by Lungman et al., which shows you the association. So if both the donor and the recipient are negative, the incidence of CMV reactivation is very low, as seen by the orange figure line over here. while if the recipient is positive, the reactivation is fairly high. However, in India, you can see that recipient and donor are positive in practically the majority. 84% of patients will be both recipient and donor positive. So the recipient negative, donor negative component is an extremely rare population, rare group of transplants in our setting. And CMV reactivation occurred in 36.3% of this population. The median time to CMV reactivation was 41 days. And here you can see in different types of settings, the amount of CMV reactivation. All of us recognize that with acute GVHD and treatment for acute GVHD, we have greater reactivation, 59.4%. With PTCY, it goes up to 64.4%. And it goes up to studying 72.7% when we have a haploidentical donor. So truly, with the increased use of haploidentical donors, we are seeing this problem much more. And our own data of patients who have CMV reactivation versus those that don't have shows a significant inferior survival in those that did have CMV reactivation. Cost of management of CMV, this has been a challenge. We've really not had much generics in this area. Ganciclovir costs about 50,000 for a course. Foscarnet about 4,50,000. And Cidofovir, one dose costs about $2,000. And that's something that we now have a generic which MCure has brought out. In CMC, we've also started viral-specific cytotoxic T cells. This is a platform where basically you take cells from the donor, you expose them to a catch matrix reagent, in this case it's CMC PEP mix, and then you pull out the interferon gamma positive cells, and we do this in-house. We've standardized this, and the QC is going as has been established. This just shows you a positive control and CD8 positive cells with interferon gamma positive. And this is actually a donor with CMV PEP mix stimulation showing you the CMV interferon gamma positive, a small proportion of cells. And this is a particular patient where the donor was a haplodonor, where the donor mother and father had both screened. And you can see this father had a better proportion of cells that reacted to the CMV PEP mix in vitro, and therefore he was chosen as the donor. He had a CD8 interferon gamma positive percentage of 3.34%, so we chose him as the donor. And this procedure, we infused our first patient with CMV CTL just 11th of June 2020. How do we identify high-risk populations? We look at haploidentical HSCT, match unrelated donor HSCT. Donor HSCT with GVHD are high risk for CMV reactivation. And another study that we are interested in is looking at CD45 depleted, RA positive depleted donor lymphocyte infusions prophylactically in high-risk patients. Within the autologous transplants, it's important to remember that patients who have received bortezomib as prior therapy have a higher risk of CMV reactivation compared to those that did not. BK virus has been another real difficult problem for us, especially as we do more mismatched transplants and haplotransplants. It's more the morbidity that patients go through with this particular disease. And this is another disease where we have used Cidofovir. So the data is not exactly impressive with Cidofovir in BK virus. And really, both medical therapies are not very effective. The pathophysiology essentially is that BK virus targets the uroepithelium, and this targeting of the uroepithelium is more when there's conditioning causing damage of the uroepithelium, along with immunosuppression, allows the BK virus to proliferate, causing epithelial damage, and the alloimmune response often aggravates this epithelial damage. And BK viruria occurs in about 50% of patients after BMT. The incidence of BK viruria is similar in allogenic and autologous, but hemorrhagic cystitis occurs in only about 20 to 25% of BMT recipients. And we monitor the urinary BK viruria copy numbers, and usually above 10 to the power of 10 copy numbers is where you see most of your hemorrhagic cystitis, though that's not an absolute. Our own data, 1,276 transplants, that's good data put together by Biju. Looking at 262 had hemorrhagic cystitis, 189 were checked for BK viruria by qualitative PCR, 105 tested positive for BK viruria. And really, this major problem is our MUDs and our haplotransplants, where up to 13.3% have frank hemorrhagic cystitis. So most patients would have asymptomatic BK viruria, for which you really don't need to do anything. But once they become hemorrhagic cystitis, for the most part, it is supportive, though we do use Cidofovir at times. I conclude by saying viral infections are a major problem in patients undergoing HSCT. There's a higher incidence in alternate donor transplants and following GVHD. CMV is the major cause of infection, followed by BK virus and respiratory viral infections. I've really not touched on respiratory viral infections in detail. We see a fair number now that we have a full panel to identify them, but the ones that really give us problems is H1N1. And of course, we have no experience with COVID. We've not had a patient with COVID at this point in time who picked this up post-transplant. Various therapeutic strategies are available, but some limited by finances. There's significant role for viral cytotoxic T lymphocytes, both in CMV and in BK pyuria. I'm going to